Bonaparte, which is perhaps one of the most powerful men in human history. And it talks about how he was inflicted by painful hemorrhoid at the Battle of Waterloo, a battle that basically ended the French Empire as we understood it historically and led to his demise. And there are a lot of fascinating historical facts in this article if you would like to look it up and read it. It's really a very fascinating article. Now, globally, colorectal surgery or colorectal procedures are a practice within general surgery or digestive surgery. Only in very few countries, it's a focus specialty. The United States is one of these few places where there's an actual board, both for general surgery, but also colorectal surgery. And typically, to become a colorectal surgeon, you have to train for 5 years in surgery. Then you have to do additional subspecialty training for 1 or 2 years in colorectal surgery, following which you have to take 4 examinations, 2 written exam and 2 oral examination to become certified in the specialty. And then that is not the end of it. Then every year you have to go through cycles of maintenance and certification to maintain your level of skills at the highest level. Now, the fascinating thing about our specialty is that it encompasses both office-based work as a medical aspect of it, where we treat patients with medication for disorders, proctologic disorders, for instance, like fissure and hemorrhoid. We also carry a large endoscopic practice where we perform gastroscopy, colonoscopy, and we also full-time surgeon in the operating room where we perform anything from proctologic surgery to minimally invasive, laparoscopic, and robotic surgery. Now, Ashok, can you still hear me with the audience? Because I don't have feedback here. If you do, just let me know so I can continue to the next section.
Yes, doctor, we can hear you, but as I said earlier, everyone is put on mute. I myself unmute myself when I want to respond to you. Otherwise, everyone is on mute. So you can continue, doctor. Thank you.
Okay. If you stop hearing me, just please let me know.
Sure, doctor.
Now, in terms of my personal background, I'm originally from Lebanon. I immigrated to the United States back in 1985. I was an athlete in my younger years, and you alluded to before, I was fortunate enough to run the 1988 Olympic Games. My medical school training was in California, below San Francisco at a university called Stanford University, following which I was fortunate enough to join the Mayo Clinic, which is, as many are aware, is the #1 hospital in the United States, where I did spend 6 years doing my surgical training, following which I went to the Cleveland Clinic and obtained my colorectal surgical training, and Cleveland is very well known in this specialty. Subsequently, I served for 10 years in Los Angeles as the director of the National Center for Excellence in Colorectal Surgery. I have an extensive academic background where both I've contributed tremendously to the field through my scientific work. I have over 150 scientific publications. I have toured the world and lectured in the various continents with over 300 American and international presentations throughout the globe. I've also have been a member of the American Board of Colon Rectal Surgery. This is the official board that train and certify the young surgeons who go into practice as colon rectal surgery. I have served on 8 editorial boards, including currently serving as the associate editor of Disease in Colon Rectum, which is the official journal of the American Society of Colon Rectal Surgeon, as well as seminars in colon rectal surgery. As an academic surgeon, as an educator, and a clinical surgeon, I'm the recipient of over 30 honor awards in recognition for the work that I've done, including one that is America Top Surgeon and another one of Super Doctor of Southern California, where I practice. I have lectured at the largest meeting to audiences in the thousands, to small webinars such as the one we are conducting tonight, to share experiences and learning with a surgeon from around the globe. Now, I came to this part of the world initially as one of the original founders of the Cleveland Clinic in Abu Dhabi, where I served as the digestive disease chairman between 2012 and 2016. before I returned again to the United States. And for family reason, I came back to Dubai, where I established my practice. As I alluded to earlier, I introduced colorectal surgery as a new specialty to UAE by being the first person to be given a license in the name of colorectal surgery, both in Abu Dhabi initially and subsequently in Dubai in 2017. My current private practice serves patients in 3 continents over a geographical area of over 8,000 kilometers. I've had patients fly from Africa, Asia, Europe, even some from England, the United States even come to care. And I do offer experience with being a surgeon for over 20 years and over 15,000 operation procedure that I have conducted through this journey. My current clinical practice is focused solely on colorectal surgery, anywhere from proctologic disorders to performing gastroscopies and colonoscopies, managing pelvic floor disorders, which we will cover a little bit. I perform a large amount of minimally invasive surgery, and I'm also an expert in reoperative abdominal pelvic surgery for patients who have undergone previous operation in the abdomen or pelvis and either failed or recurred, such as cancer or surgical complication. I have tremendous expertise in treating those patients. My current practice is in 2 hospitals. One is Zahra Hospital, which Ashak spoke about earlier, and I also practice at King's College Hospital, London as well. Now, with that personal background and also a specialty background, I'd like now to shift to a focus on what are some of the disorders and conditions that we treat. In terms of abdominal disorders, probably the most common one we deal with are inflammatory bowel disease, such as Crohn's disease and ulcerative colitis. And depending on which part of the world you come from, the prevalence of these 2 disorders may vary. Diverticulitis is a global phenomenon, and we're seeing an increasing trend towards younger and younger patients who present. Colorectal cancer and polyp, which we will discuss, is something that we deal with every day as colorectal surgeon. And we also deal with the colorectal emergencies such as ischemia, bleeding, obstruction issue, or volvulus. Now that was for the abdominal aspect. For the pelvic floor and anal aspect, obviously proctology is a big practice. For us, we deal with the anorectal disorders such as hemorrhoid, fistula, fissure, human papilloma, virus infection, and warts. We deal with pelvic floor incontinence issues. We deal with vaginal fistulas in women, whether they're spontaneous or whether they're related to childbirth. We also deal with functional disorders such as abdominal pain, acidity issue, which is something we see even though our focus is not the upper GI, but often patient will come with both abdominal pain, dyspepsia, constipation issues, and so forth. Now, in terms of inflammatory bowel disease, for those who are not familiar with it, it's basically an immune phenomena where there's inflammation of the intestinal tract. You can also have extra-intestinal manifestation of inflammatory bowel disease, such as in the skin, the joint, the eye. When it comes to Crohn's disease, it's basically a full thickness, thickening of the intestine and the surrounding fat, which can lead to fistulization or obstruction. And ulcerative colitis is predominantly a mucosal-based problem where you get inflammation of the lining of the colon, and that can lead to diarrhea issue and bleeding issue. Now, when we look at Crohn's disease, unlike ulcerative colitis is a disorder that inflicts the colon and the rectum. However, the Crohn's disease can impact the digestive tract anywhere from mouth to anus. The most common area of involvement is the terminal ileum, but realize that patient can have upper GI involvement, whether the mouth, the esophagus, the stomach, the duodenum, but also in lower GI, they can have involvement of the anal canal with ulceration or fistulas, as well as the colon, where they can get Crohn's colitis. And these are evidence of what happened when Crohn's disease become advanced. This is a patient that has, here you see on the right side, demonstrated by the blue arrow, is a long segment of colon that is inflamed and strictured. And if you look at the left panel here, that has led to chronic obstruction where the cecum is significantly dilated, occupying about 1/3 of the circumference of the abdomen. And you see here on the right side of the CT scan, where I'm pointing with the white arrow, you see thickening of the descending colon, which is inflamed as well. So this patient has Crohn's colitis with the stricturing. And this is another manifestation of Crohn's disease, which is basically perforation of the intestine that can lead to abscesses. The colon here you see has a little bit of contrast, which is the white material, and behind it you see this large inflammatory mass with some gas. This is a sign of perforation. Now, another common disorder we deal with is diverticulitis, and it's important to realize that diverticulitis creates a tremendous burden on the healthcare system. In the United States alone, over 300,000 cases every year, with over $2.5 billion in healthcare costs. And if you were to look endoscopically at patient with acute diverticulitis, you would see the endoscopic picture on the left, where you see erythema and edema of the intestinal wall. And on the right panel, you see on the CT scan, you see this long segment that is inflamed. The fat around it, the area I'm pointing with the white arrow, is infiltrated with inflammation. You see narrowing of the lumen due to the edema, and you see a little bit of contrast that is going through this segment of acute diverticulitis. And this is how it looks like in the most severe form. If you have to operate on it, you see the outpouching of the colon here. This colon on the left side is chronically inflamed, very thickened. And in this colon on the right side, you have acute perforation with pus and holes in the colon. Both of these patients I operated on. Now, it's important to know that this paper was by a colleague with whom I published some other work on diverticulitis, that the fastest growing subgroup in terms of age are the young, the 18 to 45. They've had 82% increase in recent years. In this study between 1998 and 2005, over 7 years, 82% increase in incidence in diverticulitis in the young. And now moving on from inflammatory disorders such as inflammatory bowel disease and diverticulitis to colorectal cancers and polyp, it's very important to realize that we need to raise jointly as physicians a lot of awareness about this, because this is a very common disease, and unfortunately, undetected, it can lead to premature death. So here in the UAE, we've done a lot of awareness campaign so that people are aware that this cancer is real. Everybody is at risk for it. I personally have already screened myself 3 times, and I do that every 5 years. It's very, very important to do that. And why is that? This data is from the United States, but this basically mirrors data from around the world. In both men and women across the globe, colorectal cancer is the 2nd to 3rd most common cancer in all type of cancer, and often it's the 2nd to 3rd cause of death, cancer-related death. So this is a global phenomenon, not only in the Western Hemisphere, but also in the Eastern world, in Asia, in Europe, in Africa. These numbers are real. And recent studies have demonstrated that there's an increasing incidence in younger people. So if you look, for instance, the American Cancer Society around 2016, 2017 published their data comparing the 1950 generation, those who are born around that time, compared to those who were born in 1990, and there was 4-fold increase in the incidence of rectal cancer and 2-fold increase in the risk of colon cancer in the younger generation. Here in the UAE, while in the past in the Western world, the median age of presentation was around late 60s to 70, in the UAE and in this part of the world, the Middle East, it's typically between the mid 40s to the mid-50s. So we're seeing a shift towards a younger generation. As a matter of fact, the vast majority of patients I have treated since I've been in practice in Dubai have been under the age of 50. Today, before I came to this webinar, I treated a young person in the early 30s with a locally advanced colon cancer already. Early 30s with a colon cancer that came in near obstructing. So this is a global phenomena. It's a real phenomena, a very common cancer in both gender with an increasing presentation at younger time. And typically, how does this evolve? Our understanding of colorectal cancer is that it starts typically with normal cells. This is, if you look at the panel on the left, shows normal epithelium or colonocyte that undergo a series of transformation. And typically it's a genetic transformation where there's a loss of some genetic material from these normal cells that gradually lead from a normal looking cell to a cancerous cells in the bottom here. And the way I explain it to patient is if you look, for instance, at animals, if you were to look at a donkey, when you look at a donkey looks like a donkey. If you were to breed a donkey with a zebra, that will look still maybe like a donkey, but you're not sure, is it a donkey, is it a zebra? If you take that further and you breed that animal with a horse, it's gonna look very different. And furthermore, if you breed that with a mule, and now you're gonna have something that looks very different than a donkey. So the analogy here is that the further this goes along, the less it looks like the original cells. So here, if you look at the upper panel, you see a normal colon, and this is a beginning of a polypoid lesion here. And if left untreated, typically within few short years, you will have an invasive cancer such as the one you look at in the bottom. So you go from normal looking colon cells, this is the upper aspect of the upper slide, to something that look a little bit different to something that look completely different. And that's the sequence of development of colon cancer, and that's why it's very important to raise awareness about screening, because with screening we can detect a lot of these lesions early at a time when we can cure them. Now, do we have any evidence that screening make a difference? Our best screening modality, and the one I advocate for my patient, is colonoscopy. And in this landmark study published in the New England Journal of Medicine back in 2012 on the impact of colonoscopy, and if you look at the patient, a general population that does not have any lesion or predisposition, if you look at the red curve, that's basically the cumulative colorectal cancer death related to those. However, if you have polyps and you aggressively follow these patients and you remove the polyp, versus if you don't do anything, and that's the top curve, patients who did not receive any treatment, you see this is the mortality in those patients, is that curve that is going up exponentially compared to patients who've had screening, colonoscopy, and polyps were removed. You may not get it to complete zero risk, but you're able to decrease it significantly compared to patients who've had nothing done. And so in order to prevent cancer, we would like to catch polyp early and have a modality such as colonoscopy where we can remove them early to avoid the recurrence of the polyp. In some cases, we want to catch the cancer when they're still early, either take them to surgery to cure them, or in some cases, we can even remove them with colonoscopy, as I will show you. We want to do this at a stage where we minimize the morbidity of any intervention we do to patient. And we have colonoscopy, which is a very cost-effective, very simple procedure to do. And the question now, in the hand of highly specialized people who are highly trained and with a very busy practices, can you even push the envelope further? And if you look here, I showed you the example in the upper panel here, a polyp, which is probably a couple centimeter polyp. It's a decent sized polyp. That in the hand of most endoscopists should be something that they're well trained to remove. But how about if you have a very large lesion such as the one in the bottom panel, a lesion that is several centimeters long, it encompasses multiple folds of the colon. You see here in the white arrow, that's one fold, that's a second fold, that's a third fold here, and extending even the fold below, and it occupies over 50% of the circumference. Can you treat that patient if you detect it early, still at a non-cancerous stage, without the need for surgery? And that's a question that was asked of me many years ago when I started getting referred patient who had very large lesion, and an endoscopist look at them and says, this needs to go to surgery. We cannot remove endoscopically. And these patients came to me with the hope of avoiding surgery. If they hadn't come to my care, they would have 100% of the time undergone directly surgery. And in this paper, landmark paper I published in 2011 in Archives of Surgery, basically described these patients. We had 104 consecutive patients who came with very large lesion. If you look here at the bottom of this table, the mean average size was greater than 3 centimeters, with some lesion as large as 9 centimeters. And the majority of these lesions were flat, and these technically can be a little bit more challenging. And this is some example of some of the lesion. Some were very low in the rectum. This particular lesion in the left upper portion of the panel, and you see here I've had complete removal in the endoscopy suite in less than 1 hour. This is another one which occupied a significant amount of the rectum. Instead of taking that patient for big pelvic surgery, I was able to completely remove the endoscopy suite. So in centers that have tremendous expertise, not only can we prevent cancer for early polyp, but we can also tackle polyps that are very large and otherwise deemed by most physicians as not feasible endoscopically. We can really push the limit and save the patient surgery. And that's better for the patient because it has much less risk and it's less costly to the healthcare system, because often these are done as an outpatient where the patient goes home the same day or with a short overnight stay. And if you look here, what is the long-term outcome of these patients? When I took very large lesion, in 83% of the time, the lesion was managed completely endoscopically. Very low recurrence rate of 7% here. 12%. Very low morbidity of 7%. Bleeding and 1 perforation. The majority of the bleeding patients we were able to manage endoscopically. And some patients required more than 1 endoscopic procedure to fully control their disease, but we were able to manage the majority of them in the endoscopy suite. No incision, no scar on the abdomen, no surgeries, and no risk of surgery. And this is just as a case illustration. This is another case that I show you here. I showed you several that look a little bit similar. When you look at this case, very large polyp. This is immediately after removal, and this basically 4 months later, you have just a scar. So again, you look at this picture here, most surgeons would have completely removed the patient rectum, sometime with a small chance of acquiring to have a colostomy bag. But here you see complete endoscopic removal, and when I scope this patient 4 months later, nothing is left, just a scar. And this is another example of a large transverse colon polyp. This is immediately after endoscopic resection. This is in a different part of the colon. And here, 3 months later, I left a tattoo to see where the lesion was. All you see is a little scar. Both of these patients were saved the morbidity and the risk of surgery with an outpatient procedure. Now, also in a select group of patients, sometimes we can push the limit by doing a combination of laparoscopic keyhole surgery with endoscopy, especially for lesions that are in difficult location. We can preserve the colon and use laparoscopy to kind of push the lesion into view where we can easily resect it endoscopically. Now, in terms of moving on to keyhole surgery, as an expert in minimally invasive surgery, this is something that I've been practicing now for over 20 years. We can tackle pretty much both benign disorders such as diverticulitis, inflammatory bowel disease, but also polyps and colorectal cancer. With the proper equipment, we can have beautiful visualization Instead of making a big incision on the abdomen with all the risk of that, we can go in with small instrument and a camera, and we can visualize. In this case, in this panel, you see Crohn's disease with all the thickening of the intestine. In the other cases are colon cancer cases. And this leads to incredible cosmesis. These are immediately after surgery. This patient here in the right upper panel. The other patient are at the first post-operative visit. You barely see small stab incision through which you are able to do colon surgery. And typically one of these incisions is a little bit larger because we have to get the colon out as a specimen. And the advantages of laparoscopic surgery are obviously less pain, shorter hospitalization. There are many patients who can leave within less than 2 days. It's improved cosmesis. Patients like it, especially the young one, because it doesn't involve big scar. Often they can return to work faster. I've had a very busy professional return to work 10 days after the surgery. We also know from the elderly, when we operate laparoscopically, less likelihood they end up in nursing home, higher chance they can go back to independent living at home. It has less cost, less adhesion, but laparoscopic surgery does require a lot of expertise to make sure that it's done properly. And this video is a woman who underwent just underwent the surgery and immediately in the recovery area, I went and I changed my clothes. And here I came to see her in the recovery area, and she's already up and walking.
You can start to. Yes, the urine is very clear. So that's really nice. So what did she have, Dr. Maher? She had laparoscopic partial colectomy of cecum and appendix. And she had a cholecystectomy, and she had cystoscopy and urethral catheter placement. In essence, she had three, one endoscopic, cystoscopic procedure, and laparoscopic procedure. She looks great.
So this is a clear example of the early recovery. So we have a program for enhanced recovery, and this patient literally, I finished the operation. The person who was speaking in the video is my colleague from anesthesia. I went to the locker room, I changed. I came to check on her on the recovery, and we're already walking the patient. And this you just don't see with any other type of abdominal surgery modality. Now, not only there are short-term advantages to this, but there are also long-term advantages. This is one of the largest studies here. It's myself operating with a fellow in Los Angeles doing laparoscopic colorectal surgery. We published this in Archives of Surgery as well, a large series of thousands of operations where we looked at the incidence of subsequent small bowel obstruction or ventral hernia, which are two potential consequences of abdominal surgery that can lead to additional operation, the need for additional operation in the future. And when we looked at these patients, when done laparoscopic compared to colleague who operated on them open, the laparoscopic patient had fewer bowel obstruction, fewer hernias, and the majority were able to be managed non-operatively. So clear advantages, not only in the short term, but the long term. We also, in my specialty, as a highly specialized person, do a lot of endoscopic intervention. This is a case of a patient who'd been operated in Egypt, was sent to me with a colon block. And when you look here at the left upper panel, this is where the bowel hookup they had connected had completely strictured and narrowed, where the patient had a large bowel obstruction. This is after I cleaned this area of granulating tissue, and I was able to manage this by opening the area with a balloon, saving the patient additional operation. We also, for patients who come in with acute obstruction, I deploy metal stent to open the colon. This is an area of a tumor here in the left upper quadrant, which came in fully blocked. Here you see in the right upper panel after deploying a stent. Immediately after that, you get decompression with stool coming through. And here you can see the stent inside opening the patient. And this made history here in the UAE. When I first arrived in practice, I performed the endoscopic decompression. I'm probably the oldest patient done in the entire region at the time, came in with stage 4 colorectal cancer, very ill, and I was able to manage that endoscopically. He did very well, left the hospital without needing the surgery, and this made news because it was very worthy outcome. Now, moving quickly to proctologic disorder. Proctology is a branch of medicine concerned with the treatment of diseases of the anus and the rectum. Often it's related to lifestyle, such as straining issues, constipation issues. Some are related to pregnancy or genetic predisposition in some families. And really, the most common disorders we deal with are anal infection, whether they're sexually transmitted like HPV, which can lead to warts, anal fistulas, hemorrhoid, anal itching from a variety of disorders, anal fissure, which is a cut that can occur. We do see anal cancer and polyps also of the low rectum and anal area. And it's important to know that we do have a lot of treatment that are non-surgical for many of these patients. Here I show the slide just out of interest. Companies have really seen an opportunity in the conservative management of a lot of these disorders, and thus have come up with a lot of creative advertisement here to try to illustrate how uncomfortable it can be for patients and how wonderful the product that they have to treat these disorders. And I must say that often it's my first line of therapy for the majority of patients. I try to avoid surgery if I can and reserve surgery only for those who either don't respond or have disorders such as abscess or fistula. Evaluating these patients, typically the majority of them, you can make the diagnosis by history, physical inspection, additional examination, and endoscopy. And if needed, if they have, let's say, rectal bleeding, any abdominal surgery, abdominal symptoms, then a sigmoidoscopy or colonoscopy. And this is a manifestation of one disorder, which sometimes can confuse doctors. These 3 patients, they all have anal hemorrhoid. Often I may see a patient like the one in the bottom panel where he is referred with the diagnosis of rectal prolapse. This is not rectal prolapse. This is a grade 4 hemorrhoid, both internal, internal component. The one here in the right upper panel have both a mixture of external covered by skin as well as internal covered by a mucosa. And we talk about 2 different types of hemorrhoid. The internal one, typically there are 2 on the right, 1 on the left, but there are patients who may have 4 or 5, and they may not all fit the classic contribution and distribution. External hemorrhoid on the outside, depending on the type of hemorrhoid and the location, they may cause different symptoms. And here an example of what Napoleon Bonaparte had, thrombosed hemorrhoid. This is a mild case of it, where you see right underneath the skin, you see this bluish discoloration or blackish discoloration, such as in the panel in the left lower. That's a thrombosed clotted hemorrhoid. The majority of them are managed non-operatively. I reserve surgery only to those who keep getting recurrent thrombosis or those who have a very large clot and are very uncomfortable, cannot walk, cannot sit. Then we intervene surgically. It's very important, again, to distinguish rectal prolapse, true rectal prolapse from hemorrhoid. If you look at the diagram in the bottom, typically rectal prolapse has a circular fold that are all around versus hemorrhoid, large hemorrhoid, which are radial fold that you see here. And that's basically the 2 patients, the one in the upper one, that's hemorrhoid, even though they're very big, that's hemorrhoid. And the one on the left there, full thickness rectal prolapse that is circular. Other disorders like anal fissure, basically, which is a cut, very painful, typically triggered by either constipation or diarrhea. The majority of time they're on the posterior midline. Occasionally they can be in the front, especially in women. You could see a hypertrophied anal papilla, which often people confuse for a polyp. This is not a true polyp. This is just a piece of skin that has enlarged, and often we treat these patients with the medication first, and if they fail, then we take them to surgery. Probably one of the few disorders that we always recommend surgery because there's no effective medical treatment for it, anal fistula, which is basically a tunnel from inside the anus to the outside The majority of these patients are related to cryptoglandular disease, which means an infection of the anal gland that can either cause a spontaneously draining fistula or an abscess that requires drainage by a surgeon. In a minority, a patient can be related to cancer, inflammatory bowel disease such as Crohn's disease, a previous history of radiation, or prior childbirth with trauma to the perineum. And this is the two manifestation of anorectal sepsis. The patient on the left has an acute abscess. There's also pus that is draining from inside the anus. The one on the right, it has a spontaneously draining fistula. The difference between the two is the one on the right can wait for elective surgery. The one on the left need to be emergently drained so that the infection does not become life-threatening. Other things people sometimes may see around the anal area are benign structures, such as the one I showed you before, the hypertrophied papillae with the fissure. Sometimes they can get very large and mimic like a pedunculated polyp. If they bother the patient, they protrude to the outside. We remove them. If they're inside and they're not causing much problem, we manage them without surgery. We do see other dermatologic problems such as yeast infection. This is very important to recognize. It's kind of like a diaper rash, which we see in the children. It typically does not improve with the hemorrhoidal medication, which people mistakenly prescribe. Important to keep the area clean, dry, and apply antifungal. Probiotic to change the consistency of the stool can help. It's important to know that in a small percentage of patients, it can be manifestation of malignant disease such as Paget disease. So if you treat a fungal rash that doesn't go away, it requires biopsy. We do see sebaceous cysts filled with the oil from the sebaceous gland. They can mimic hemorrhoid, neoplasm, or abscess, but they typically have a certain characteristic. They're not painful. They don't have any redness associated with them. They're not ulcerated, and the only effective way is to excise them surgically. Now, the human papillomavirus has great burden on humanity. We see over 100 different types of human papillomavirus. It has a significant burden on the anal area. It can cause anywhere from small warts, such as the upper panel, to very large fungating mass, such as the one in the bottom. And one more advanced cases of HPV-related disease when they develop anal dysplasia. When I was in Los Angeles, I took care of over 1,500 HIV-positive men, and there we followed them very closely, because when you immunosuppress, the HPV can get out of hand and cause, in the early stages, dysplasia. These are the changes here where they start having chronic irritation of skin that doesn't heal. Typically most prominent in men who have sex with multiple men, immunosuppressed, smoker, but I've also seen it in women and in people who are not smoker. And more advanced, they turn into an anal cancer. And this is very important because often these patients are misdiagnosed. There are delays in treatment where for many months they don't receive any treatment, and people keep giving them creams and suppository for hemorrhoid. These are not hemorrhoid. These, when they look like this, especially if there's an ulcer associated, they typically either inflammatory bowel disease such as Crohn's, or when they look like this, this is invasive carcinoma, and this need to have immediate recognition and immediate treatment to minimize the threat to the patient life. Now, the last few slides in terms of some of the intervention we have to treat patient. For hemorrhoid, if they are internal, probably the most successful one, if they have focal symptom and they protrude out, typically rubber band ligation, one of the oldest and most established treatment. I still believe it helps a lot of patients. We could do infrared coagulation, which some people for marketing purposes refer to as laser. This is not laser. It's a form of energy here where you have a halogen bulb that transmits light to the tip of the applicator here, and then you can apply it to the area just above the hemorrhoid in order to scar the hemorrhoid inside. We can ligate these under Doppler energy and sound in the operating room. That's a THD procedure where we lift the hemorrhoid up into the anal canal and we shrink them in size. True laser, typically, unlike the infrared, is done in the operating room where we basically burn and coagulate the internal hemorrhoid. This is how it's delivered, where we make a small puncture and deliver the laser energy into the hemorrhoid itself. And this is immediately before the procedure and the completion. This is with the patient still on the operating room table. This is how it looked initially, and this is how it looked at the end. In terms of minimally invasive treatment for fistula, it's important to know that there's a variety of treatment that we have for fistula. Traditional ones such as a draining seton, a thread that we put in. There have been glues and plugs that people have used, laser closure, videoscopic surgery, removal of the fistula, closure with a flap or a lift procedure. You don't need to remember the name, but realize that in the hand of highly specialized expert, we have a variety of intervention that we can offer the patient. And I've been an expert in anal fistula treatment. I've written extensively on it, including book chapters, including the book chapter in the official journal and the official textbook of the American Society of Colorectal Surgeon. I contributed to the book chapter on anal fistula and complex colonic fistula, as well in various textbooks on the various techniques that we have. Laser is not for every patient, but there are patients who can benefit from laser, where we put a probe, a flexible probe through the fistula tract, and we burn it. We also have videoscopic intervention, where we basically can go in and obliterate the fistula tract by coming through the videoscopic equipment through the outside and going inside and burning the entire tract. And lastly, again, it's very hard to take my entire specialty and present it in 45 minutes, but the hope was to try to give you some general idea about the disorders and some of the technology we have. We also implant pacemaker in advanced cases of pelvic floor disorders, such as patient with fecal incontinence. This is a great technology, especially in women who are incontinent after multiple childbirth. This could be really life-altering and can basically lead to much improved quality of life. And it's something I offer here, and I performed the first one in the UAE in Abu Dhabi many years ago. So this is a brief overview on a personal note, again, as a colorectal surgeon who's highly dedicated to the treatment of disease of colon rectum. And not only do I bring to the table the latest and most advanced technologies, knowledge, and expertise, but my private practice has been led by three values: the compassion, providing the patient with the most compassionate care, with excellent result, and at the highest level of integrity, only providing the patient the care that they need. If it's something that I can resolve for them without the need of surgery, I will do that, whether it's medical management or endoscopic management. And if they require to have an operation, we will perform the operation with the highest level of expertise, with the best possible outcome for the patient. I thank you very much as the audience for logging in from around the world. I also would like to thank Ashok and Anavara for hosting this webinar to try to kind of spread some knowledge around the globe about the specialty of colorectal surgery in a nutshell. Obviously, there's a lot more highly specialized topic within my specialty, but we kept it a little bit general for a general audience. And at this stage, I'm really more than happy to take any question you may have. And I'm gonna exit the screen so I can see the questions.
Yeah. Thank you very much, Doctor. It was a pleasure having you on board and you explaining about this in layman's term. You know, sometimes it becomes difficult to put a hard subject into a layman's term, but with the pictures and other things that you showed us today, including that video, I think most of us learned a lot of things. So I request everyone, if you want to put some question, please put it in the chat box so that we can ask the doctor about it. If we are not able to finish the question and answer session now, then probably we can collect it and send it to you by email, because we do have your email addresses and we can send it to you. So if you have your questions, please start having it. Zakir, you said, may I ask a question from Bangladesh? You are welcome to type it out here.
Okay, thank you so much for giving me the time to ask a question. I am Mr. Zakir Hussain from Bangladesh. I have been working for the people for 3 decades in the fringe of a forest and forest area also. So I like to know from you that under our as we know person who to get the treatment under you, do you have any kind of sponsor? Do you have any kind of opportunity to get sponsor to reach you to get the treatment under you?
So if you need to come to Dubai for treatment, I encourage you to get in touch with Ashok, who can help with coordination of care. That would be the easiest way. If there are question or specific cases or condition, you can forward him the file, and then we can advise. If something that doesn't require to come here, happy to provide you with the advice of how to handle it. Or should you come here, he can coordinate for you the travel plan, the appointments, and you can also, if there's need for procedures or operation, an estimate can be given to you in terms of what the cost of care and so forth. So you have a clear idea, either for yourself, for family, or for patients, what to expect and anticipate.
Okay, thank you so much for giving me the good answer about regarding my questions. And how do can be able to communicate along with you in this regard? I got the email from Anavara. Should I send the email at that email ID?
Yeah, I just sent you the email ID. It is info@anavara.com. It will be picked up by anyone. And as the doctor clearly pointed out, if there is no need or necessity to come to Dubai for the treatment, then you can just have an online consultation with the doctor, and we could solve it. So it is best to send the medical report or whatever information you have, so that we can share with the doctor.
Okay. Thank you so much. Thank you so much. I got the pleasure to join along with you in the at this event. Thank you so much.
You are welcome. You are welcome, Zahir. Thank you very much.
Bye.
Thank you. So, doctor, I have a question. We have referred some clients to you in the past, and what is the duration during, or if some patient is above 45 years, how often do you think that they should have a colonoscopy to diagnose?
Yes, so we're going to talk about two different patient populations. So we're going to talk about the patient population that is at significant risk and those who are at average risk. So we'll start first with the average risk. Average risk meaning that there's no additional risk factor in the patient family history that would basically trigger an earlier screening. For those patients, the American Cancer Society, which subsequently these recommendations were endorsed by the American Society Colorectal Surgeon, we dropped the age to 45. We actually wanted to drop it down to 40, but there was not enough man and woman power to care for all the patients screening-wise. So we decided to go from 50 to 45 if patient is asymptomatic and has no significant history. At 45, and typically every 10 years, you need to have a colonoscopy. However, I also advise patients to have interval screening with stool studies. So typically, if a patient is going to go to 10 years, I may say every 2-3 years, get a stool specimen for blood or calprotectin. And if it's elevated, then you do the colonoscopy sooner. But at minimum, every 10 years, a colonoscopy with some stool studies in between. Now, this is for screening average risk. There's also screening of patients who have significant family history. And the easiest way to kind of think about it is the 3-2-1 rules. So the number 3, the number 2, the number 1. And that history is basically 3 family members that are directly connected. So that's father, daughter, uncle, nephew. mother, son. So 3 members of the family that are connected across 2 generations. So generation of father, son, mother, daughter, uncle, nephew, and so forth, with 1 family member under the age of 50. So if you're taking the history from a patient and they have 3 family members at least across 2 generations, with 1 under the age of 50 developing a cancer, and the cancer type would be colorectal cancer, breast cancer, some other cancers like gastric cancer as well, ovarian cancer or uterus cancer. So all of these cancers, they don't necessarily need to be colon cancer. They are digestive tract or the gynecologic tract. If you have 3 patients in the same family, 2 generations, 1 under the 50, then that family is at a higher risk. Obviously, it's even higher if all of these are colorectal cancer, meaning if someone says, I have many family members who died young of colorectal cancer, then that's a significant family history. Or a family that has a history of polyps, like familial, and we did not get into these disorders, but if they say, you know, we've had 5 family members, they all have polyps, 1 of them or 2 had cancer, 1 died, or family history sometimes that you cannot elicit, meaning, well, my grandpa and his brother and 1 of the uncle died, but they thought maybe cancer, but we don't know what type, because in the older days, often they may not have known or they may not have received the care necessary to document what type of cancer. So all of these are significant histories. For those, the screening recommendation will be younger. And that become a little bit more complex because some we may start screening in their teenage years. So if there's a strong family history of polyposis, condition where they have hundreds of polyps, we will start screening those family members or testing them genetically very, very early on in life. For other disorders, we may start at age 25 for the first colonoscopy. So there you need to kind of seek the opinion of someone specialized to kind of guide the situation. And the last thing to basically share with you is that these are screening recommendations for asymptomatic. That is very different than if you have someone who has symptoms. So you may get someone who's 20 years of age who has no family history, but comes in with recurrent rectal bleeding. They need a colonoscopy. So there the purpose is not really to screen, but more to diagnose what is the source of the bleed. Because these patients, they may tell them it's a hemorrhoid bleeding until someone looks inside and they have a rectal cancer or colon cancer. So it's important to know that screening recommendations are for asymptomatic patients in 2 groups: asymptomatic average risk or asymptomatic with an increased risk, versus diagnostic colonoscopy, which is for patients with symptom. Could be abdominal pain, it could be sudden onset of constipation, it could be distension, it could be rectal bleeding. Now, I'll move on to the next case. Why there's an increased risk in colorectal cancer among young people and how do we prevent it? That I think is a very, very important question. So we can speculate that probably the 2 biggest driving factor that are contributing to that is a sedentary lifestyle. As we become a creature of modern life, we are not exercising much, we are not moving much. People are now glued to their smartphone, to their computer screen, to the television screen. The level of physical activity has gone down significantly. For those in the audience who are 30, 40, 50 years old, you remember when you were a child, most of the fun you had and the entertainment, the game were just getting outside the house and playing with your friends. Nowadays, you see kids just sitting home playing with devices. So there's a major sedentary lifestyle component here, which is contributing to that. The second one is the way we're eating. And increasingly in societies across the globe, we're relying more and more on other people fixing our food, and often fast food, because what happened with everybody living on the run, people are consuming more and more and more fast food, processed food. And we know that these 2, a sedentary lifestyle and poor nutrition, are by far the two leading component. Now, additional risk factor, genetic factors like family history, that is a small percentage, can vary anywhere from 5 to 15%. But the bulk of it is sedentary lifestyle, poor diet, obesity. We were seeing an increasing amount of obesity across the globe. Smoking is another one that is contributing not only to lung cancer, but also to other type of cancer in the body, including digestive tract cancer and urinary cancer, such as the bladder. Now, lastly, there's also have been some studies on vitamin D, that a vitamin D deficiency may be a culprit in that. And if you think about it, many of us, because we have more and more sedentary lifestyle, we're not spending enough time outside. And vitamin D metabolism depends on sun exposure. And with less sun exposure, we see an epidemic across the globe of vitamin D. And there have been some studies that have speculated that a lack of vitamin D is a contributor. This work obviously will continue to evolve in the future as people do more and more scientific study to figure out whether that is a true phenomena or not. But for now, encouraging people to eat healthier food, encouraging people to exercising more. If you have patients who smoke, encouraging them to stop smoking, and if people are overweight, to decrease their weight. All of these are very important intervention, not only for colon cancer, but for a variety of other disorders, including cardiovascular disorders and diabetes.
Thank you, doctor. I have one last question. Is there any genetic markers for this? Like for breast cancer, there are some genetic markers which you can identify. Are there any genetic markers for this?
Yeah, so the genetic markers, so there are tumor markers and genetic markers. So we'll start with the simple part. The tumor markers are basically, and I see that a lot, people getting screens with tumor markers where people order on them a blood test for tumor marker. Typically, we don't use tumor marker for screening. We use them for people with established disease to monitor baseline level of disease, and also after treatment and intervention to monitor that. Now, in terms of genetic testing, so that's tumor markers that looks at the presence or absence of tumor. None of them are perfect, but they can be helpful in management of patient with cancer. In terms of genetic testing, typically we don't advise a genetic screening, not as of yet. It may become, as technology evolves further and further, it may become a thing of the future. But currently, we don't advise genetic screening because the currently commercial platform are very expensive. Often they are in several $1,000s. Obviously, people who have a lot of money may elect to obtain it. The majority of insurances do not cover it. And the problem is two things. One is they don't screen for every genetic disorders we have. And two, if you get a positive result, what do you do with it? Because even in some cases where you may be carrying the gene, in some cases there is 100% likelihood that you would develop cancer. So if you look at familial polyposis, for instance, if you have true familial polyposis and you don't remove the colon and the rectum, the likelihood of developing colon cancer by the age of 40 or 50 is nearly 100%. However, for other type of genetic syndrome like HNPCC or the Lynch syndrome, by the time you're 80 years of age, the majority of patients would not have the cancer. So it's not 100%. You may have 60, 70% of them that may get the tumor, but you may have 20 or 30% that never develop the cancer. So for those reasons, currently, we have not used genetic tests for screening. We have used them more to guide the care of young patients to understand, do they have one of the established genetic syndrome? Are they at risk of other cancers that we need to look for and screen for? And how do we handle the offspring? If they have young children, what kind of counseling can we give to the young children to say, look, you know, your dad or mom has this cancer. this is a genetically transmitted, we need to test your children to see whether they have it or not. And if they have it, then we can basically surveil them, do like surveillance tests to make sure that at the earliest experience of that cancer, we treat it. So genetic screening, no. Genetic diagnostic for patient with established cancer, especially the young one, yes, we do have tests, and they are being now used with an increasing frequency.
Thank you, doctor. It was quite interesting, because I was thinking that this is like a confirmatory test, but thanks for letting us know. I think you know who I'm referring about, one of the very famous personalities in White House now who had a genetic screening. So I don't want to tell the name here. That's why I asked this question.
Sure.
So we have not got any more questions, and we are also past the 1 hour time. Thank you very much for taking your time, doctor, and all of you for joining us. It was a very educative session for all of us, including me, who I am a layman. So we really thank. I want to clap, but I don't know whether we can do this. But thank you very much, doctor, and thank you everyone for joining us.
Thank you.
Shared in the YouTube, and we will share this link to all of you folks. Thank you very much.
Yes, thank you very much. Bye-bye now.